Welcome to the Deep Dive, the show that takes complex information and distills it into practical, actionable insights for you, our dedicated orthopedic professional. Today, we're tackling a challenge many of you face in the clinic, that complex distal humerus fracture, say in an 80-year-old, with a quite osteoporotic bone. Do you attempt a heroic open reduction and internal fixation that, well, might ultimately fail, or do you turn straight to arthroplasty? We're going to embark on a crucial discussion today, navigating the intricacies of total elbow arthroplasty and distal humeral hemiarthroplasty. We want to help you make those critical decisions, examining the indications, the surgical nuances, and of course the critical outcomes that shape patient care. To guide us through this detailed landscape, we're joined by an expert whose insights in musculoskeletal surgery are simply invaluable. Professor, it's a genuine pleasure to have you with us as we unravel this often debated clinical dilemma.
Thank you. It's a privilege to be here and delve into this topic. Elbow arthroplasty, especially in the context of acute trauma, truly represents a significant paradigm shift in how we manage some of the most challenging upper limb injuries. This is particularly true in our rapidly aging population, where, as you say, bone quality often presents formidable obstacles. Understanding the nuances here is absolutely paramount for optimizing patient benefit and ensuring, good long-term functional success.
That point about patient independence and functional outcomes is so critical, isn't it? Our mission today is to extract the most important insights for you, whether you're considering these procedures for your patients, perhaps managing postoperative care, or simply staying abreast of the latest evidence in this rapidly evolving field. We'll unpack the evidence and clinical considerations that underpin decision-making in this quite demanding surgical domain. So let's begin by setting the stage. Historically, complex distal humerus fractures, particularly in the elderly, presented significant treatment challenges that, frankly, often left both patients and surgeons feeling quite frustrated. Could you elaborate on why elbow arthroplasty has gained such prominence as a primary treatment option? Why is it stepping out of the shadows as merely a salvage procedure?
Certainly. It's really a story of necessity driving innovation. Distal humerus fractures, they have an incidence of approximately 5.8 per 100,000 per annum, and they occur most frequently, quite strikingly actually, in older female patients. The epidemiological data is quite compelling. One large study reported a seven-fold rise between 1970 and 1995. So this demographic shift, coupled with the inherent complexity of these injuries in osteoporotic bone, really set the stage for a new approach. Traditionally, severely comminuted fractures, especially in fragile osteoporotic bone, were often managed non-operatively. We sometimes refer to it as a bag of bones approach. The aim was simply to achieve some form of union, often with significant deformity. The unfortunate reality was that this often led to malunion, sometimes pseudoarthrosis, and frankly profoundly poor functional outcomes for the patient. We're talking persistent pain, severe stiffness, and a severely compromised ability to perform basic activities of daily living. It really undermined their independence.
That's devastating for someone previously active.
Absolutely.
Yeah.
Imagine an older individual, previously independent, now struggling to even lift a teacup or brush their hair because of a severely compromised elbow. It was and still can be a real clinical dilemma. Now, the advent of modern fixed-angle locking plates in the 1980s was indeed a game changer. It made open reduction and internal fixation, ORIF, the predominant surgical technique. And, in the absence of surgical complications, ORIF generally showed improved outcomes compared to that older bag of bones approach.
It wasn't the whole answer, especially for older patients.
Exactly. For patients over 65, particularly those presenting with significant intra-articular comminution or severe soft tissue injuries, or just frankly poor bone quality, ORIF has reported complication rates as high as 44%. Non-union and metalwork failure are significant concerns in the elderly. The bone simply struggles to hold the fixation securely. It often leads to a frustrating cycle of repeat surgeries. And even when we do achieve union, patients can still suffer from persistent pain, motion deficits, and eventually post-traumatic arthritis. This often severely limits their activities of daily living and independence, undermining the very goal of the initial treatment.
So the potential downsides of ORFF in that group are quite substantial.
They really are. And this is precisely where total elbow arthroplasty, TEA, and more recently distal humeral hemiarthroplasty, DHH, have truly come into their own. The core insight here for clinicians listening is that in these specific patient groups where comminution is severe, bone quality is poor, or perhaps previous fixation attempts have failed, the traditional ORIF approach, despite its advancements, can sometimes become a trap. It can lead to worse long-term outcomes and a higher burden of complications than considering a primary arthroplasty. TA and DHH offer a more reliable way, arguably, to restore function and independence in this challenging patient cohort. They essentially bypass the inherent difficulties of achieving stable fixation in fragile bone. It's about providing a more predictable and often superior functional outcome when traditional fixation is either technically impossible or just highly prone to failure.
That truly underscores the critical need for these alternatives. So, for the discerning orthopedic clinician facing these difficult cases, what are the primary indications? When does TEA become the preferred, maybe even the frontline treatment pathway? Are there specific fracture patterns or patient characteristics that immediately flag a patient for arthroplasty consideration?
Yes, absolutely. The core indication for TA is indeed those severely comminuted distal humerus fractures that, by all assessments, are considered effectively unfixable through traditional ORIF methods.
Oh.
This is often due to extensive bone loss
Hmm.
or severe osteoporotic changes that just render the bone unable to hold fixation securely. Screws and plates simply won't purchase adequately.
Right.
Or in instances where previous surgical attempts have unfortunately failed, leaving a really challenging revision scenario. It's particularly relevant, as we've said, for the elderly population, where anatomical reduction and stable internal fixation of these comminuted fractures are especially challenging due to the inherently fragile nature of osteoporotic bone. We're talking about situations where the fragments are too small, too numerous, or the bone is just too soft to rely on traditional methods.
And beyond the acute fracture itself?
Well, exactly. Furthermore, TEA is an excellent option for patients with pre-existing, perhaps advanced osteoarthritis or significant post-traumatic arthritis where the elbow joint is already significantly compromised before the fracture. In these cases, joint replacement often offers a much better quality of life compared to the often debilitating pain and stiffness associated with fixation techniques that might preserve a fundamentally damaged joint. Even specific fracture types, like very low transcondylar fractures with inadequate bone stock, or highly complex injuries involving both the medial and lateral columns of the elbow, can be prime candidates for arthroplasty.
So it's about the fracture, the bone, and the pre-existing joint health.
Precisely. It's not just about the acute injury. It's about the underlying bone quality, the patient's functional demands, and the long-term health of the joint. The growing recognition of ORIF's limitations in certain scenarios, coupled with significant advancements in prosthetic designs and surgical techniques, which we'll discuss, has definitely broadened the scope of TEA. It's made it a frontline, proactive option in many complex scenarios, rather than just being a last resort salvage.
Okay, that's very clear. Now let's focus specifically on total elbow arthroplasty, the TEA. You mentioned the critical distinction between linked and unlinked implants. Could you clarify these concepts for our listeners, perhaps with a stronger analogy, and explain why linked TAs have really become the dominant choice, particularly in these trauma settings?
Yes, it's a crucial distinction, and one that's often oversimplified, I think, leading to some misconceptions. Think of linked like a true door hinge. The humeral and ulnar components are physically connected, usually by a pin or an axle. This mechanical connection provides inherent stability, making dislocation almost impossible unless the implant itself breaks or, crucially, loosens from the bone.
Like a solid hinge.
Exactly. Unlinked, on the other hand, means the parts are entirely separate, much like the ball and socket joint of the hip or shoulder. Their stability relies entirely on the natural shape and congruency of the implant surfaces and the integrity of the surrounding soft tissues, the ligaments, the capsule. Now, the terms constrained and semi-constrained refer to how much freedom of movement the design itself allows. A constrained implant acts like a very rigid hinge. It offers maximum inherent stability, but potentially transmits more stress to the bone-implant interface, which could be a downside.
Right, leading to loosening.
Potentially, yes. A semi-constrained design offers a bit more give or sloppiness, like that Kunred-Mori sloppy hinge we'll talk about. It aims to mimic natural elbow motion more closely, allowing a few degrees of varus valgus and rotational movement. Theoretically, this reduces stress on the bone-cement interface. The key thing is both linked and unlinked implants can be designed to be constrained or semi-constrained. It's about the design philosophy.
Okay, that clarifies the terminology. So why the strong trend towards linked in trauma?
Well, for trauma cases, the trend strongly favors linked TEA. The UK National Joint Registry data paints a very clear picture here. Linked TEAs accounted for over 38% of all TE cases in 2020. That's a significant increase from 19.4% back in 2012. And this rise is largely driven by acute trauma indications. The primary advantage of a linked implant, especially in acute fractures, is its inherent stability. It simply cannot dislocate unless there's a structural failure of the implant itself or its fixation to the bone.
So you're not relying on healing soft tissues for stability.
Precisely. This completely negates the need for soft tissue or epicondyle healing to achieve implant stability, which is often severely compromised in acute fracture settings where ligaments might be torn, avulsed, or otherwise damaged. Unlinked TEAs for trauma are far less common, precisely because they require a very robust repair of the collateral ligaments and epicondyles around the implant to provide adequate stability. And that's often simply not feasible in the context of severely comminuted fractures with significant soft tissue injury. While unlinked designs theoretically have lower loosening rates due to reduced constraint, clear evidence of their superiority in trauma settings is currently lacking in the literature, and that instability risk is a major hurdle.
That's a fascinating insight into the evolution of implant design and the rationale. You mentioned the Kunrad-Mori prosthesis evolving into a sloppy hinge. What was the driving force behind that specific design change? Was it purely biomechanical, or were surgeons seeing specific clinical failures with the older rigid hinge that pushed this evolution?
That's an excellent question, and it really gets to the heart of implant development and iteration. Looking at specific designs, the Kunrad-Mori prosthesis by Zimmer Biomet is globally the most widely used linked design, and its evolution is indeed quite fascinating. It started as a much more rigid hinge, yes. However, surgeons observed that this rigid constraint, while providing excellent stability, was transmitting significant stress to the bone cement interface.
The weak link, essentially.
Exactly. This led to higher rates of aseptic loosening of the humeral and ulnar stems, particularly in more active patients, or over longer follow-up periods. The driving force behind the evolution to the sloppy hinge, which allows approximately 7 degrees of varus valgus movement and some internal-external rotation, was precisely to address this loosening problem. By allowing a small amount of physiological play, it more closely mimics the natural joint kinematics, redistributing forces and reducing those peak stresses at the bone-implant interface. It was a direct response to clinical observations of early loosening and a better biomechanical understanding of how the native elbow actually moves.
And what about the newer designs? Are they addressing other issues?
Yes, newer designs such as the Latitude by Stryker, the Discovery by Biomet, and more recently the Nexel by Zimmer Biomet, they attempt to address other potential issues. A key one is polyethylene bushing wear, which has been a long-term concern with any linked implant involving moving parts. Finite element analysis, the computer modeling, suggests that these newer designs might produce lower contact stress on the bushings. But here's where it gets really interesting for us clinicians. Clinical data demonstrating a clear, consistent advantage over the well-established Kunrad-Mori is still, well, quite limited.
So the jury's still out on whether newer is definitively better in practice.
In some ways, yes. In some registry studies, the data is even contradictory, with suggestions of higher revision rates with some newer models compared to the Kunrad-Mori. This highlights an ongoing dilemma. Do you stick with the proven, albeit older, workhorse that has decades of follow-up data, or do you embrace newer designs with theoretical biomechanical advantages but less robust long-term clinical evidence?
A common theme in orthopedics.
It is indeed. It's a constant tension in our field, and it underscores the need for more robust, long-term clinical evidence for these newer generations before widespread adoption, particularly for trauma indications where the demands are high.
That's incredibly insightful. Beyond the implant itself, what are the fundamental surgical principles and approaches clinicians should be aware of when performing a TA for a fracture? And perhaps more importantly, what are the critical choices or steps that distinguish excellent execution from merely adequate? Where can things go wrong?
Right. Patient positioning is absolutely vital. It ensures optimal surgical access, intraoperative maneuverability, and of course, patient safety. Surgeons typically opt for a lateral decubitus or supine position, ensuring the entire extremity is prepared and draped to allow for full range of motion assessment during the procedure itself. A sterile tourniquet is optional, but commonly used to minimize bleeding, though the procedure can certainly be performed without one if needed.
And the approach. You mentioned avoiding disrupting the triceps.
Yes, when it comes to the surgical approach, this is where critical choices come into play. Methods that violate the extensor mechanism, such as performing an olecranon osteotomy or using triceps-reflecting approaches, are generally discouraged for both TEA and DHH in the trauma setting.
Why is that so important?
Because triceps-sparing approaches, like the lateral parallel or the paratricipital approaches, offer significant advantages. They allow for immediate rehabilitation without the need to protect a triceps repair. This means earlier active motion for the patient and fewer postoperative restrictions, which is a huge benefit. Furthermore, they provide a more robust, soft tissue envelope, which is critical in minimizing wound complications, a concern that's amplified in the often compromised tissue of a trauma patient. Critically, in acute trauma, the removal of the articular fragments often provides sufficient access to the joint anyway, negating the need to disrupt the extensor mechanism at all. This is a key technical pearl that really reduces morbidity.
Makes sense. What's your preferred approach?
Our preferred approach, for example, is the lateral parallacranon approach, often combined with a medial paratricipital window. This combination provides comprehensive access to both the medial and lateral aspects of the joint, which is often necessary in these complex fractures. A key initial step is making a posterior incision, carefully avoiding the olecranon tip to prevent skin necrosis, and then meticulously raising full-thickness fasciocutaneous flaps. A critical consideration, which impacts a notable percentage of patients, around 5 to 10%, is the ulnar nerve. It's located in a very vulnerable position medially.
Ah, yes, the ulnar nerve. Always a concern around the elbow.
Absolutely. Our preference is generally to transpose the ulnar nerve anteriorly at this stage, moving it safely out of the surgical field to protect it during instrumentation and implant insertion. While decompressing it along its length and leaving it in situ is another acceptable option for some surgeons, the paramount concern is always ensuring the nerve is entirely free of tension or impingement after the implant insertion and wound closure. Failing to do that can lead to persistent and debilitating ulnar nerve neuropathies, which can be a significant source of patient dissatisfaction, even if the arthroplasty itself is mechanically sound. This attention to detail with neurovascular structures is simply non-negotiable.
Absolutely critical. Now, switching gears slightly, Professor, you mentioned distal humeral hemiarthroplasty, or DHH, earlier as an emerging alternative. Given the complexities and perhaps the lifelong activity restrictions associated with TEA, how is DHH stepping in to address some of those challenges? What's fundamentally different about its approach and design philosophy?
That's a perceptive question, because DHH truly represents a strategic evolution, trying to find that sweet spot. The driving force behind the increasing interest in DHH stems from its potential to offer the primary advantages of TEA, namely reliable function restoration in complex fractures, while importantly bypassing some of the specific complications associated with the linked articulation, the ulnar component, and the polyethylene-bearing surface of a traditional TEA.
So it replaces left of the joint.
Exactly. Fundamentally, DHH involves replacing only the capitellum and trochlea of the distal humerus with an articular-shaped spool that's attached to a humeral stem. Crucially, it leaves the native ulna and its articular surface intact. This means it inherently avoids issues like polyethylene wear, which is a long-term concern with linked implants. It also eliminates the risk of aseptic loosening of the ulnar component simply because there isn't one. Perhaps most appealing to certain patient groups, it aims to reduce the strict lifelong activity restrictions often associated with linked TEAs, which can be quite limiting for patients who are previously active or have higher functional demands.
That sounds like a significant advantage for some patients.
It potentially is. The idea is to restore the humeral side, maintain the native ulnar articulation, and rely on the patient's own ligaments for stability. Currently, the Latitude EV by Stryker is, in fact, the only licensed DHH implant available globally. It's a modular cemented implant featuring a flange stem and an articular spool joined by a cannulated pin. This central cannulation through the center of rotation is a notable and clever design feature. It specifically allows for robust collateral ligament repair directly through the implant. This is vital for stability in an unlinked system.
And convertibility.
Yes, a significant clinical advantage, which offers surgeons considerable peace of mind, is its convertibility. If, intraoperatively, instability is unexpectedly encountered, or if revision is needed down the line, the prosthesis can be revised to a full TEA without requiring the extraction of the existing humeral stem. This simplifies future interventions and makes any potential revision less invasive. The UK National Joint Registry data clearly highlights a year-on-year increase in DHH use for trauma. A substantial 89% of UK cases in 2020 were performed for acute trauma. This underscores its growing acceptance in this specific clinical context, particularly perhaps for younger elderly patients.
So DHH seems promising, but it's an unlinked articulation, meaning it relies heavily on soft tissue integrity. You mentioned the ligament repair. What are the specific prerequisites for considering DHH over TEA? Are there particular patient profiles or fracture patterns where one is clearly favored over the other? This sounds like a critical patient selection dilemma.
You've hit on the key challenge with DHH stability. Because DHH is an unlinked articulation, its stability relies heavily, as you say, on competent collateral ligaments and the surrounding soft tissues, unlike a linked TE, which provides inherent mechanical stability. Therefore, it's relatively contraindicated in patients with pre-existing symptomatic ulnohumeral or radiocapitellar joint osteoarthritis. The native articular surfaces that remain must be healthy and pain-free.
Makes sense.
It's also not suitable where primary ulnohumeral stability cannot be achieved due to severe ligamentous disruption or chronic instability. Concurrent coronoid fractures can also be problematic due to the heightened risk of postoperative instability. The coronoid contributes significantly to the anterior stability of the elbow, acting as a buttress.
So the list of must-haves is quite specific then.
Yes, the prerequisites for DHH consideration are quite precise, and these are really non-negotiable for success. You need 1. No pre-existing symptomatic arthritis in either the ulnohumeral or radiocapitellar joints. 2. No concurrent coronoid fracture that compromises stability, or at least one that can be very stably fixed. 3. Intact or reconstructible medial and lateral columns of the humerus, as these provide key attachment points for ligaments. And critically, number 4. Intact or reconstructible collateral ligaments. If these conditions aren't met, the risk of instability becomes unacceptably high, leading to failure.
And patient profiles, is it mainly for younger patients?
In terms of patient profiles, DHH is generally considered for slightly younger patients, perhaps late 60s to early 70s, whose higher activity levels might lead to aseptic loosening of a TE over time due to greater stresses on the implant. It's also potentially suitable for those who would struggle to adhere to the strict, lifelong activity restrictions often associated with a linked TEA. For example, if a patient relies on their upper limb for ambulation or transfers, or perhaps is involved in light manual labor, the less stringent restrictions of DHH might be beneficial.
But still with caution in the truly young.
Absolutely. It's crucial to note that current evidence suggests the best results for both TEA and DHH are still observed in older, less demanding patients. Any arthroplasty should be used with caution in younger patients due to limited long-term data and the inherent lifetime risk of revision surgery. Prosthetic longevity is simply a major concern for younger, more active individuals. Also, the presence of a concurrent radial head fracture is generally seen as a relative contraindication for DHH. In that situation, TEA might be preferred due to the increased risk of overall joint instability when both radial and ulnar supports are compromised. It's truly a procedure for very specific indications and careful patient selection.
That's very clear. Now, Professor, beyond the choice of implant, the success of elbow arthroplasty hinges on truly meticulous surgical technique and planning. Could you walk us through the critical preoperative considerations and then delve into the details of the surgical steps, particularly focusing on the critical judgment calls or moments of highest risk where a surgeon's skill really shines, especially regarding implant positioning?
Absolutely. Preoperative assessment is exhaustive, and it's really where the foundation for a successful outcome is laid. It involves taking a thorough history, including any previous elbow injuries, any instability, contracture, or infections that might complicate the procedure or influence the chosen approach. We also diligently screen for systemic diseases like significant heart conditions, severe uncontrolled diabetes or hypertension that could potentially preclude surgery or significantly increase its risks. Crucially, patients must provide a comprehensive list of all medications, especially those affecting coagulation like NSAIDs or anticoagulants. These may need to be stopped well in advance to reduce the risk of excessive bleeding intra- and postoperatively.
And imaging. You mentioned CT scans.
Yes, imaging is paramount. In addition to standard plain radiographs, multiplanar computerized tomography, or CT, is incredibly useful. It provides a detailed, three-dimensional assessment of the number, site, and size of articular fragments. This is more than just looking at the anatomy. It helps the surgeon mentally reconstruct the elbow, plan for any bone loss, and preoperatively determine if arthroplasty is truly the most appropriate treatment option.
So it helps avoid changing plans mid-surgery.
Ideally, yes. We want to avoid an intraoperative conversion from an attempted fixation if possible. That can significantly prolong operating and anesthetic times, increasing patient risk and resource utilization. For very complex cases, we might even utilize 3D printing from CT data to create patient-specific models for preoperative templating and even practice, which can be invaluable.
And are there specific criteria you use to decide for arthroplasty and acute fractures?
Yes, we only proceed with elbow arthroplasty for an acute fracture if 5 key criteria are met. These are our guiding principles. 1. The fracture reconstruction is just not reliably feasible through traditional means due to bone quality or severe comminution. 2, the patient must be medically fit enough to tolerate a significant surgical procedure given its complexity and duration. 3, they must be deemed likely to be compliant with postoperative rehabilitation protocols. These are absolutely critical for functional recovery and implant longevity.
Compliance is key.
Absolutely. 4, They should clearly benefit from the reconstruction, meaning they are an active or independent individual whose quality of life would be significantly enhanced by restoring elbow function. We generally avoid these complex procedures on patients who are very sedentary or profoundly unwell. And finally, 5. Primary soft tissue coverage and closure of the wound must be achievable. A typical fracture pattern, ideally suited to arthroplasty, is a very distal fracture, primarily involving the articular block, often characterized by multiple fragments and poor bone stock, what we might classify as a modified Dubberly type 4 fracture. Low transcondylar fractures with significant bone loss are also prime candidates. Interestingly, open fractures are not an absolute contraindication if they are non-contaminated and can be primarily closed. Studies have shown no increased infection or complication rates with acute primary arthroplasty in such selected cases, which broadens our treatment possibilities.
Okay, once those critical decisions are made, what are the key intraoperative steps, especially regarding humeral and ulnar preparation and that precise implant positioning? Where does the surgeon's skill really make the difference?
Indeed, precision is everything in this procedure. Even small errors can have significant long-term consequences. After the initial incision and careful retraction of muscles, tendons, and ligaments, always protecting the ulnar nerve, which we've discussed is paramount, the damaged articular fragments of the humerus are meticulously excised. A crucial anatomical landmark here is the roof of the olecranon fossa. This bony structure almost always remains continuous with the humeral shaft, regardless of how comminuted the fracture is. It serves as the safe entry point for opening the humeral canal. Reamers and broaches are then directed slightly anteriorly from this starting point to ensure satisfactory sagittal plane alignment of the implant, recreating the native anterior bow of the humerus.
Getting the length right seems crucial too.
Absolutely. For the humerus, broaching is done sequentially, gradually preparing the canal to accommodate the stem. Achieving correct implant length is critical for restoring the native range of motion, avoiding over-tensioning of soft tissues, and preventing issues like impingement or instability. We use the laser line often found on the broaching instrument, ensuring it's parallel to the flexion-extension axis of the humerus. In cases where the native bony landmarks are disrupted by the fracture, we can provisionally reduce the fractured condyles around the shaft, as the flexion-extension axis is inherently parallel to the inferior margin of the medial epicondyle. This is a crucial trick for maintaining anatomical accuracy in a chaotic fracture environment.
And rotation, how do you judge that?
Implant rotation is equally vital. Getting it wrong leads to asymmetric forces across the implant, which can cause premature wear or loosening. It's like ensuring your car wheels are properly aligned. In acute fractures where the native epicondylar axis is disrupted, a reliable reference is the posterior humeral line, the axis of the flat bony surface proximal to the olecranon fossa, which is typically intact. The implant should then be implanted about 10-15 degrees internally rotated relative to this line to match the native rotation of the elbow joint. Getting this wrong can lead to maltracking, impingement, and early failure.
And preparing the ulna.
For the ulna, the articular surface of the olecranon is removed, often precisely with a bell saw or high-speed burr, creating a flat surface perpendicular to the long axis. The ulnar canal is then opened at the coronoid base and broached sequentially to the desired size. Ulnar component rotation is referenced from the native radial head and/or the flat dorsal surface of the ulna, ensuring the correct rotation is parallel to this surface. It's noteworthy that ulnar component pistoning, where the implant moves back and forth slightly in the canal, can occur due to impingement between the coronoid and the anterior flange of the humeral component, if the ulnar component is implanted too distally.
Another potential pitfall.
Yes, it's not just a technical detail, it's a subtle yet critical error that can lead directly to aseptic loosening and early revision. Meticulous depth assessment here is paramount to ensure free articulation throughout the range of motion.
And then cementing.
After trials confirm satisfactory implant position, stability, and full range of motion, we're looking for smooth, unrestricted movement without impingement. The components are cemented into place. We utilize a third-generation cementing technique with low-viscosity cement inserted in a retrograde fashion using a cement gun and narrow nozzles. And why does that matter so much? Because this technique, coupled with appropriate canal preparation and pressurization, helps achieve a superior, uniform cement mantle. A robust cement mantle is arguably one of the most critical factors in preventing early aseptic loosening, directly impacting the longevity of the implant for our patients. Cancellous bone graft, often harvested from the resected articular fragments, is then frequently used to augment the anterior humeral cortex, providing additional structural support to the humeral component, especially where bone might be deficient.
And finally, that critical ligament repair for DHH.
Yes, finally, and this is especially critical for the unlinked DHH. The repair of the collateral ligaments is absolutely essential to avoid instability. We employ a robust, multi-layered technique involving multiple high-strength sutures for each epicondyle. We carefully dissect any epicondyle fragments with attached ligaments, cast whip stitches through the cannulated spool of the DHH implant, and secure them as mattress sutures to the opposite epicondyle or surrounding soft tissues. This epicondyle fixation is then further augmented, often with a tension band suture through small drill holes in the humeral columns, and perhaps cerclage sutures through the central aperture of the humeral stem, essentially lashing the soft tissues back down securely. Even larger epicondyle or metaphysis fragments can sometimes be fixed with Kirschner wires into the cement mantle, or even small plates, particularly if there are large fragments involving the metadiaphyseal cortex. This meticulous, multi-layered approach ensures the necessary stability for an unlinked design, which is its inherent Achilles heel if not properly managed surgically.
That detailed explanation of the surgical process, particularly the precise measurements and the robust, multi-layered repair techniques, truly brings the complexity to life. It makes clear why these procedures are often best performed by experienced surgeons. Professor, postoperative care is just as crucial as the surgery itself for achieving a successful outcome, isn't it? What are the immediate concerns, and how do the long-term rehabilitation considerations fundamentally differentiate between TEA and DHH? This is where patient compliance and a tailored approach really come into play.
Indeed, the postoperative phase is where the patient's journey to recovery truly begins, and it demands meticulous attention from the whole team. Immediately after surgery, patient monitoring is intense and focused on pain management and infection prevention. Pain management is tailored to individual needs, often combining pharmacological interventions like multimodal analgesia, regional blocks, opioids, and NSAIDs with non-pharmacological strategies like ice and elevation. A temporary drainage tube may be inserted in some cases to manage surgical fluid in the immediate postoperative period, although routine drains are perhaps less common now than they once were. Critically, meticulous wound hygiene and maintaining sterile surgical conditions are paramount to minimize infection risk. Infection rates can unfortunately vary quite widely, from maybe 1% to as high as 12.5%, depending on various factors, patient comorbidities, and fracture severity. Early detection of any signs of infection is absolutely critical.
And how about immobilization?
Regarding initial immobilization, if soft tissue quality around the elbow is poor or deemed vulnerable, perhaps a patient with very thin skin or extensive bruising, the elbow may be splinted and semi-extension for maybe 7–10 days to protect the soft tissues and allow initial wound healing. However, in most instances, particularly with a well-performed triceps-sparing approach, a simple wool and crepe bandage is typically sufficient for comfort and light support. Elevation of the limb is strongly recommended for the first few days to manage swelling and reduce pain. Patients are encouraged to perform gentle hand and shoulder exercises from day one to prevent stiffness in adjacent joints. For DHH, we often prefer to avoid extension splinting altogether. This is due to the inherent risk of instability in an unlinked construct if the ligament repairs are placed under undue stress early on. It's a fine balance between protection and early motion.
And the rehab protocols differ significantly.
Yes, they fundamentally differ between DHH and linked TEA, reflecting their distinct design philosophies and stability mechanisms. For DHH, once the wound has healed sufficiently, early rehabilitation focuses rigorously on maintaining movement while providing robust protection to those critical ligament repairs. We often advocate a supine overhead rehabilitation protocol. This position helps to increase joint compressive forces and promote dynamic elbow stability, allowing for early active motion while specifically avoiding varus or valgus torque on the joint.
So, specific restrictions are needed.
Yes. For example, shoulder abduction might be restricted to less than 45 degrees for about 6 weeks to reduce any undue varus torque on the healing elbow. This is done alongside concurrent shoulder exercises to prevent a frozen shoulder. It's about controlled motion within safe limits. For linked TEA, because of its inherent mechanical stability, unrestricted motion can typically commence much earlier, often once the wound has healed, usually within days of surgery, especially if a triceps-sparing surgical approach was used. No routine splinting or braces are generally required for linked TAs. The goal is simply to regain full, pain-free range of motion without the same concern for instability.
And long term, what advice do patients need?
Long-term, patient education on activity and loading is absolutely critical for both types of arthroplasty. This is key to ensure prosthesis longevity and prevent premature failure. For linked TEA, some guidelines recommend avoiding single-event lifting over, say, 5 kilograms and repetitive lifting of any object over 1 kilogram. This is primarily to minimize polyethylene wear and reduce stress on the stem fixation. However, our practice often focuses more on educating patients about the rationale for avoiding heavy activity and high-impact loading, rather than imposing potentially stringent and sometimes impractical weight limits that patients may struggle to adhere to.
So understanding why is more important than a strict number.
I think so. It's about understanding the mechanics, the potential for wear and loosening, and protecting the implant as a lifetime investment. For DHH, while activity restrictions are generally less strict than with linked TEA because it preserves the native ulnar articulation, patients are still advised on responsible and mindful use. This is to maximize prosthesis longevity and prevent undue stress on the native ulna and the reconstructed ligaments. It's a lifetime commitment to care for these implants, really, and patient adherence to these guidelines is paramount for long-term success.
Absolutely. Professor, let's turn to the hard data, outcomes, and complications. For our medical audience listening, understanding the expected functional results and the potential pitfalls is paramount. What do the latest registry studies and systematic reviews tell us about functional outcomes and implant survival for both TEA and DHH?
Right, the functional outcomes for both procedures are generally quite encouraging. They provide significant improvements for patients who are often struggling with the debilitating aftermath of complex elbow fractures. For TA, the average Mayo Elbow Performance Score, or MEPS, reported in the literature is around 89.5. This falls squarely into the good to excellent functional categories. The MEPS assesses pain, arc of motion, stability, and function, giving us a good comprehensive functional snapshot. It's particularly notable that patients undergoing surgery within 7 days of their injury demonstrated significantly better outcomes in some studies, achieving MPS scores exceeding 90 points. This really underscores the potential benefit of early intervention in appropriate cases.
And range of motion.
The reported range of motion is also quite satisfactory for daily living activities. We typically see a mean flexion-extension arc of about 102 degrees and pronation-supination of around 145 degrees. This comfortably meets the minimum functional requirements for most daily tasks, like eating, dressing, and personal hygiene.
That's good functional recovery. How long do these implants typically last?
When we look at implant survival rates for TEA, they are quite favorable, demonstrating pretty robust long-term success. Studies show around 94% survival without revision at 5 years and maybe 75% survival at 10 years. This indicates that the vast majority of patients maintain functional integrity of their implant over a significant period. Data from the UK National Joint Registry shows an 8-year revision rate of about 6% for TEA, specifically performed for acute trauma. The primary reasons for revision being aseptic loosening or infection. The Swedish Joint Registry reports similar positive findings, with around 90% survival at 10 years, which is excellent for an upper limb arthroplasty.
And for DHH, the data is newer there, I imagine.
Yes, for DHH, long-term data is admittedly more limited, given it's a more recently adopted approach and still primarily for specific indications. However, a recent meta-analysis of published studies reported a revision rate of about 4%, though the range was wide, from 0 to 15% at a mean follow-up of 49 months. Crucially, all of these reported revisions were conversions to TEA, primarily for aseptic loosening or periprosthetic fracture. This highlights that DHH, if it fails, is usually salvaged with a full TEA, often without needing stem removal. UK NJR data for DHH reports an 8% revision rate at 2 years, predominantly attributed to instability or infection, which aligns with its unlinked nature and reliance on soft tissue repair.
And function after DHH.
The mean MEPS for DHH is reported as 83.6, also signifying good elbow function. The mean flexion extension arc is around 107 degrees and pronation supination about 153 degrees. These are well within the range required for functional daily activities, and perhaps slightly better than those typically reported for TA, though we need to be cautious about comparing across different studies and patient groups.
Are there direct comparisons?
Well, what's fascinating here is a recent systematic review that did find patient-reported outcome measures, PROMs, and range of motion to be superior after DHH compared to T for acute fractures, with similar complication rates. However, this was considered low-level evidence due to study limitations and patient heterogeneity, so it's certainly not a definitive conclusion that DHH is always superior. Importantly, preliminary results from a Swedish randomized controlled trial, a much stronger level of evidence that directly compares DHH and TA, show no statistically significant difference in PROMs or range of motion at 2 years. This is a really important emerging insight. It suggests both options provide good short-term functional outcomes in carefully selected patients, allowing surgeons to choose based on patient-specific factors, the fracture pattern, and their own expertise.
Those numbers provide a clear picture of success, but as we know in surgery, no procedure is without risk. Could you detail the short-term and long-term complications associated with these procedures? Perhaps touch upon the overall complication rates and what clinicians should be actively vigilant for post-operatively.
Certainly. Understanding the potential complications is absolutely critical for comprehensive patient counseling, informed consent, and proactive management. Short-term complications for elbow arthroplasty include, well, neurovascular injuries. These are rare but serious with an incidence rate around 1–2%, typically involving the ulnar nerve as we discussed. Wound healing issues are also a concern, as are infections. Reported infection rates vary quite widely, from 1% up to 12.5% in some series. This really underscores the importance of rigorous sterile technique and appropriate antibiotic prophylaxis.
And deep infection is a major problem.
Oh, absolutely. Deep infections can be catastrophic. They often require multiple debridements and sometimes even removal of the implant, leading to highly complex salvage situations, sometimes even amputation in extreme cases. Dislocations can also occur, particularly with unlinked designs like DHH, if that soft tissue repair is compromised. This necessitates careful postoperative monitoring and sometimes early revision.
And the longer-term issues.
Long-term complications pose significant challenges and are the primary reasons for revision surgery later on. Aseptic loosening is one of the most common causes of implant failure. It occurs due to stress shielding, micromotion, and mechanical issues at the implant-bone interface. This can lead to pain, loss of function, and eventually the need for revision surgery. The survival rate of implants varies, but as we said, total elbow arthroplasties show a mean 10-year survival rate of approximately 90%, meaning around 10% might experience loosening by that point, requiring further intervention. Paraprosthetic fractures are another significant long-term concern, occurring around the implant stems. They are particularly challenging to manage due to the often limited and fragile bone stock in the upper extremity following a previous arthroplasty. They often necessitate complex revision strategies with custom implants or perhaps allografts. Triceps insufficiency, or weakness of the triceps muscle, can also arise. It's reported between 0.4% and 2.4% of cases. This can be due to surgical injury during the approach, delayed healing, or muscle atrophy. It significantly impacts the patient's ability to extend their elbow, highlighting the importance of meticulous surgical technique, especially regarding the extensor mechanism.
So what's the overall complication rate estimate?
The overall complication rate associated with elbow arthroplasty is estimated to be around 21.5%. That's quite high compared to hip or knee replacement. Common specific issues include ulnar nerve symptoms, whether that's numbness, tingling, or weakness, and paraprosthetic fractures, both occurring in approximately 4.7% of patients in some large series. Other rarer complications may include stiffness, heterotopic ossification, extra bone formation, and skin necrosis, particularly in areas of compromised soft tissue. It's also worth noting, as we discussed earlier, that the choice between linked and unlinked implant designs can influence outcomes. Linked implants provide inherent stability but carry risks of hinge loosening due to the constraint, while unlinked designs, relying on soft tissues, may naturally have higher dislocation rates if the ligamentous repair isn't robust or doesn't heal properly.
What do the big registries show about revisions?
Looking at registry trends provides a broader, real-world perspective beyond controlled clinical trials, which is very valuable. In a Danish registry study, for instance, 21% of primary TEAs underwent revision. The most common reasons were aseptic loosening, paraprosthetic fracture, and prosthesis dislocation, specifically for unlinked TAs. The infection rate in that particular series was 7.4%. A Scottish registry study reported an even higher 18-year mean revision rate of 15%, with a 10-year cumulative infection rate of 11%. Similarly, the Norwegian registry reported a 15% failure rate after 10 years for primary TA. These numbers really underline that while highly effective for the right patient, these are not without significant risks and potential long-term issues. It requires careful consideration and robust follow-up. This is why judicious patient selection is just so paramount.
Absolutely. Beyond the surgical aspects and technical challenges, Professor, are there specific patient-related factors that significantly influence outcomes and complication rates? Things clinicians must consider during patient selection. It sounds like tailoring the procedure to the individual is absolutely key.
Absolutely. Patient-specific features play a truly crucial role and must be meticulously evaluated during patient selection. This isn't just about the elbow, it's very much about the whole patient. For instance, while historically rheumatoid arthritis was the most common indication for TEA, overall outcomes are actually reported to be worse in patients with osteoarthritis and trauma compared to those with rheumatoid arthritis. This is an important distinction when managing expectations and predicting results, as the underlying bone quality and inflammatory status differ significantly between these groups.
And comorbidities like diabetes.
Yes, diabetes is a significant independent risk factor. Diabetic patients are associated with prolonged hospital stays and significantly higher rates of various perioperative complications. We're talking about serious events like cerebrovascular attacks, pneumonia, myocardial infarction, deep venous thrombosis, and importantly, wound infection. The impaired microvascular circulation and compromised immune response in diabetic patients really compound the surgical risk, making wound healing more challenging and infection much more likely.
What about obesity?
Obesity is another major concern. Particularly a body mass index, or BMI, over 40 kg at 2 is a strong risk factor for both early and late complications, including infections. It also significantly increases the risk of needing a revision TEA, sometimes even doubling that risk in some studies. The increased mechanical load on the implant, the technical difficulties during surgery due to soft tissue bulk, and potentially compromised tissue quality in obese patients all contribute to these higher risks.
And smoking.
And finally, smoking. An analysis from a large U.S. database showed that smoking was associated with a nearly 7-fold increased risk of infection following TEA. This is largely due to its vasoconstrictive effects, impairing blood flow to healing tissues. These patient factors, diabetes, obesity, smoking, they multiply the risks of an already complex operation. Therefore, in patients with multiple significant comorbidities like uncontrolled diabetes, severe obesity, or active smoking, alternative treatment methods should be very carefully considered. The potential adverse effects of surgery seem to be severely compounded in these cases. It might mean a less aggressive surgical approach, or even opting for conservative management might ultimately be safer and more beneficial for that particular patient. It's about risk stratification.
That's a critical point about risk stratification. Given these complexities and potential complications, what non-surgical and other surgical alternatives exist for these difficult elbow fractures, and when are they typically considered? It's crucial for listeners to understand the full spectrum of options.
Yes, absolutely. For less severe fractures, conservative, non-surgical management is certainly appropriate and is always our first consideration when feasible. This typically involves managing pain with medications such as nonsteroidal anti-inflammatory drugs, NSAIDs, modifying activity levels to prevent further injury or stress, and sometimes utilizing splints or casts to stabilize the joint and facilitate healing without the need for surgery. If these non-surgical interventions provide significant relief and the fracture pattern allows for a good functional outcome without fixation, for instance, a non-displaced or minimally displaced fracture in reasonable alignment surgical options may indeed be avoided. That's always the ideal scenario for the patient, reducing their overall burden of care.
And when surgery is needed, but maybe not arthroplasty.
Right. When surgical intervention is necessary, open reduction and internal fixation, or OFF, remains a commonly employed technique. It's considered the gold standard for many distal humerus fractures, especially in younger, healthier patients with good bone quality. This procedure involves meticulously realigning the bone fragments and then securing them with screws, plates, or other fixation devices to allow for biological healing. Advances in plating techniques over the years, particularly with locking plates, have significantly enhanced the success rates of OR-OFF for many fractures, making it a viable and often preferred option for many patients who have adequate bone quality to support fixation. It's a workhorse for a reason.
But when OR fails or isn't suitable?
Exactly. As we've discussed, when ORIF fails due to complications such as non-union or malunion, or when a salvage procedure is required because primary fixation just isn't feasible or has failed catastrophically, then TEA becomes a critical consideration. This is particularly true for elderly patients with severe comminution of the fracture, or for those with a history of failed ORIF where the bone quality is severely compromised. Beyond TE, other surgical alternatives to joint replacement do exist, though they are often reserved for specific, often challenging scenarios where arthroplasty might not be suitable or perhaps has already failed. These include, firstly, resection arthroplasty. This aims to relieve pain by simply removing the damaged joint surfaces, essentially creating a gap that fills with fibrous tissue. It unfortunately sacrifices significant elbow function and stability, but can be a pain-relieving option for very low-demand patients, or perhaps those with severe infection where an implant cannot be safely placed.
So pain relief, but poor function.
Generally, yes. Then there's interposition arthroplasty. Here, transplanted tissue like fascia, muscle, or even an allograft is placed between the joint surfaces to preserve bone and hopefully some function. This theoretically reduces the risk of implant loosening compared to prosthetic options, but functional outcomes can be quite unpredictable. And finally, arthrodesis. This is where the joint is surgically fused to provide absolute stability and eliminate pain. However, it comes at the significant cost of completely sacrificing motion at the elbow. This is rarely done for the elbow unless there's absolutely no other viable option, as loss of elbow motion is highly debilitating for upper limb function.
So quite drastic alternatives.
Yes, each of these alternatives has its own significant set of trade-offs, and the choice depends entirely on the patient's specific needs, their functional demands, overall health, and the precise nature of their injury or problem. It's truly a multidisciplinary decision, often involving complex discussions with the patient.
Professor, looking ahead now, what do you see as the key developments or shifts needed to further improve outcomes, and importantly, the broader adoption of elbow arthroplasty given its current complexities? Where is the field heading?
This is where the future of elbow arthroplasty is heading, and it's really a multifactorial path. It encompasses research, training, and healthcare organization. Despite its increasing use and promising outcomes for selected patients, especially for complex distal humeral fractures in the elderly, we critically need further long-term outcome and comparative data, particularly for DHH. We're still in the relatively early stages with DHH compared to TEA, and understanding its true longevity, its specific failure modes, and potential long-term challenges is essential to refine our indications and confidently advise patients. What does a DHH look like at 15 or 20 years? That data is still emerging.
And surgeon experience matters a lot here.
Tremendously. Importantly, the relatively low annual incidence of TEA means that individual surgeon experience accumulates quite slowly in non-specialized units. This is a crucial challenge for quality and consistency of outcomes. Evidence from registry studies, such as those in Scotland and Finland, consistently shows that revision rates are significantly higher for surgeons performing fewer than, say, 5 procedures per year. Conversely, outcomes are demonstrably better in specialized, higher-volume institutions.
Suggesting centralization is needed.
Yes, this strongly advocates for what we often call a hub-and-spoke model, where complex elbow arthroplasty procedures are centralized to these high-volume units. This concentration of expertise not only demonstrably improves patient outcomes due to increased surgeon proficiency and dedicated team experience, but it also fosters innovation in techniques and prosthesis design. And crucially, it enhances education and training for the next generation of orthopedic surgeons. It's about building centers of excellence where volume drives expertise and expertise drives better outcomes.
Makes perfect sense.
While total elbow arthroplasty can provide excellent individual outcomes and restore significant function, its overall risks, when viewed from a population level, remain relatively high compared to hip and knee surgery, which are far more common and have lower complication profiles. The path to even greater success and broader, safer adoption is multifactorial. It absolutely requires meticulous patient selection, especially when considering patients with significant comorbidities like diabetes, severe obesity, or a history of smoking, where the adverse effects of an already risky operation seem to be compounded. We need better predictive models to identify these high-risk patients preoperatively.
Any technological advancements on the horizon?
Looking further ahead, I certainly anticipate advancements in patient-specific implants, perhaps using 3D printing, which could further optimize implant fit and potentially reduce stress shielding. Bioabsorbable materials for temporary fixation, perhaps in DHH to enhance ligament healing, or advancements in regenerative medicine to address soft tissue deficiencies around the elbow, are also exciting avenues of research. The integration of artificial intelligence in preoperative planning could perhaps help surgeons predict the ideal implant position and size with even greater accuracy in the future. But ultimately, centralizing these complex procedures to specialized units and fostering collaborative, high-quality research between these high-volume units are essential steps right now. This will allow us to establish robust, evidence-based clinical practice guidelines and ultimately significantly enhance the overall results and safety for patients undergoing elbow arthroplasty worldwide.
What a truly insightful and comprehensive discussion. You've provided such a clear, detailed overview of elbow arthroplasty for fractures, navigating everything from the intricate surgical techniques to the crucial long-term outcomes and those critical considerations for patient selection. It's abundantly clear this field demands a highly nuanced, evidence-based approach from orthopedic professionals.
It's been a pleasure. I think the key takeaway for any clinician listening is indeed that delicate balance. The balance between the significant functional gains these procedures can offer, which can be truly life-changing for many patients, and the absolute imperative for meticulous patient selection, precise surgical execution, and diligent postoperative care to mitigate the associated risks. The ongoing advancements in prosthetic design and the increasing understanding gleaned from robust registry data will continue to refine our practice, hopefully making these procedures even safer and more effective over time.
Indeed. For you, our valued listener, we hope this deep dive has provided you with the clarity and detailed understanding needed to navigate this complex area of orthopedic surgery. We encourage you to consider how these insights might inform your clinical practice and patient discussions, especially when faced with those challenging distal humerus fractures in older patients. If you found this deep dive valuable, please take a moment to rate and share this deep dive with a colleague who might also benefit from this expert discussion. And perhaps a final thought to consider. What's one aspect of postoperative rehabilitation for elbow arthroplasty that you find most challenging in your practice, and why? It's worth reflecting on. Share your thoughts and continue the conversation in your own clinical communities. Thank you for joining us on the Deep Dive.